I'm pleased to inform you that GPC England has overwhelmingly voted to accept the negotiated agreement with NHS employers on changes to the GP contract for 2017-18. In line with policy from the 2016 LMC conference and the results of our survey of the profession, our aim in these negotiations has been to provide stability, to secure funding to address practice expenses, increase core resources, and to tackle unnecessary bureaucratic workload which takes vital time away from clinical care for our patients. We fought hard for changes which we believe offer significant improvements to the contract and will benefit and better support GPs and practice teams. Before going into the detail of the agreement, I would like to make clear from the outset that these annual changes to the contract cannot in themselves address or resolve the crisis affecting general practice. This is largely a result of wider pressures outside our contract, with soaring demand, a critical shortage of GPs, inadequate NHS funding, excessive regulatory burdens, and unresourced and inappropriate workload shift. We've therefore been in parallel discussions with NHS England and the Department of Health on tackling these wider issues through ensuring that NHS England honours its commitments in the GP Forward View, as well as those we are taking forward through our urgent prescription for general practice. I will now run through the main changes in the contract agreement for 2017-18. Please do visit our website for full details. Avoiding unplanned admissions enhanced service. We've negotiated that the Avoiding Unplanned Admission DES will be discontinued on 31st March 2017 and that the associated £157.6 million will be added to the global sum. This will end considerable bureaucratic workload for both GPs and staff. Instead, the revised contract will require practices to focus on the management of patients aged 65 and over living with severe frailty and who will be identified using an appropriate tool. Please note this funding will be in your core budgets. There are no forms to fill and no claims to make, and GPs will be managing patients in accordance with their clinical judgment. It's estimated that severely frail patients comprise 0.5% of the practice population, which is considerably lower than the 2% population in the current enhanced service, allowing GPs and nurses more time to focus on patients in greatest need. CQC fees. We have secured for the first time full reimbursement of practices' total CQC fees. Although the GP Forward View suggested compensating practices for future CQC fee increases, we've gone further and negotiated that the entire CQC fee paid by a practice will be reimbursed. This means that CQC's recently announced exorbitant fee rises will not impact on practices as part of the total practice cost being paid for by NHS England. Indemnity. We've secured £30 million to cover the rises this year in indemnity insurance costs relating to GMS services, and has been based on information provided by medical defence organisations. This will be paid separately to practices on a per-patient basis and will not be Car-Hill weighted. As this funding will be paid direct to practices, GP partners should ensure that the appropriate amount of funding reaches their salaried GP colleagues. Locum GPs will need to ensure that their invoices with practices are uplifted appropriately to take account of this business expense. Sickness cover reimbursement for GPs. We've negotiated a significant, important improvement to GP sickness cover reimbursement. This will no longer be a discretionary payment, but a practice entitlement. The qualifying criteria based on list size, which often prevents a practice from being able to claim a payment to cover locum costs, has been removed. Payments will be made after 2 weeks of a GP being absent from the practice due to sick leave. As part of our agreement, existing GPs within the practice can now be used to cover sickness, mirroring existing maternity cover arrangements. The amount payable for sickness cover has also been uplifted to £1,734 per week. This reimbursement should reduce out-of-pocket locum expenses and the level of locum insurance needed, as well as enable practices to offer better sickness absence terms to salaried GPs. Expenses. We have agreed funding to cover the cost of expenses to result in a pay uplift of 1%. This includes £2 million to account for increases in practices' workload as a result of changes to the primary care support services provided by Capita. We've also agreed £3.8 million funding for expenses for increased employer superannuation costs and £1.5 million for the workforce census, which most practices are currently already doing with no recompense and which will now form part of the contract. Learning Disabilities DES. We have negotiated that the sum paid per health check in the Learning Disabilities DES will increase from £116 to £140, a 20% rise. This better recognises the work involved and will hopefully facilitate an increased uptake in the number of medicals done. Core opening hours and extended hours DES. Following the publication of the recent National Audit Office report, NHS England made clear its intention to address instances where practices are closing for half days on a weekly basis and are also being paid under the extended hours DES to offer additional appointments. New conditions will therefore be introduced, which will mean that practices who regularly close for a half day on a weekly basis will not ordinarily qualify to deliver the enhanced service, although there may be exceptions, such as in some branch sites. We have secured that no changes will be made to the qualifying criteria of the DES until October 2017 to allow any affected practice time to make appropriate arrangements. Access to healthcare. As part of the agreement last year to take this work forward, we have now agreed with NHS employers contractual changes that help to identify patients from Europe with a non-UK issued EHIC or S1 form. This is to assist the NHS reclaiming fees for hospital treatment from the country of origin, with which the UK has reciprocal arrangements. Please note that patients themselves will not be charged. New patients will be asked to self-declare whether they hold either a non-UK issued EHIC or an S1 form on a revised GMS1 form, and this information will be recorded in the patient's medical record and a copy of the registration form for such patients sent to NHS Digital. New recurrent investment of £5 million will be added to Global Sum to support any associated administrative practice workload. GP Retainer Scheme. We've negotiated significant improvements to the GP Retainer Scheme. A new scheme has been agreed to replace the existing one with increased funding and a number of key changes. There will also be contractual requirements to enable data extraction of the National Diabetes Audit and some agreed indicators no longer in QOF and retired enhanced services. Most practices have enabled this extraction already. In summary, I've outlined the main revisions to the GMS contract, and details of this and other smaller changes are available on the BMA website. I hope you agree these contract changes represent a tangible improvement that will support GPs and staff at this pressured time. Thank you.